All right, guys. Well, hey, welcome back to the next episode of the Own Your Life podcast. I'm Mike, usual with
Jonathan.
And man, we have a special guest. He has 3 names,
I'm Doc.
but he goes by one,
Yeah, Doc.
which is Doc.
Dr. Faglie of Enso Direct Care.
So we are our location has been officially revealed. We film at the end of the parking lot at Direct Enso Care, which Doc is the proud owner of.
Yes, that's
Yeah.
correct. And actually, you've used this equipment by far more than anybody. So it's
We appreciate
which
it.
We consider it a blessing because, we collaborate on so many things, and then this equipment gets used. So it's kind of nice. This is my office. So, once a week, y'all come over, I vacate, y'all record, and it's great.
Cool part is we're expected, actually. So we get met at the door and
Yep.
they know that, oh, hey there, it's recording time again. So
Yeah. And I consider it just the opportunity to collaborate because, we're doing something so much bigger in that overall we have a conversation about health, right? And I'm kind of confined to my little medical world where I'm doing, prescribing medicine, checking lab, but y'all are in a very different world, having to do with the overall subject of health. So I just think that's why we try to keep an open spirit of collaboration is that it just kind of, what we have found, and I think you would say the same thing, is it just kind of garners a larger conversation or promotes it
Beautiful.
like we're having right now.
Exactly, and that's what I was going to say. That's what we're here today to do. So I wanted to hit a couple basic questions and points. One of the questions we like to ask everybody on this show as we get them in is we want to ask them the question, what is health? What does that mean to you? And then whether we get there naturally or I'll ask again later, but I want to kind of go through your journey of what your career looked like prior, why you have your own practice now, and what that kind of process looked like. So I'll let you pick which one you want to start with. You want to start with what is health, or do you want to start with your story? Let's go. What is health?
You want to go?
Let's go. What is health? I want
you
to start.
sure?
Yeah, I want people to hear your version of it and then be like, where did this guy come from? And then we're going to answer it.
Yes. Okay. So health is an organism's ability to detox and adapt. In essence, health is a measure of an organism's fittedness to that organism's environment. Okay, shoot.
let's go. Guys, so
The ability to adapt.
Detox and adapt.
yeah. Doc and I talk about this all the time whenever he's up here when we get done recording or if I come over. Mike and I come from the coaching of the fitness, like getting people in and doing the things. And Doc comes from more of the data analytical of like, let's look at labs, let's look at what's going on. But, and you mentioned the collaboration thing. It's refreshing because a lot of times with doctors, like we don't always get that conversation, but like what made you start looking at like adaptability as a form of health? Because I don't think that's how most doctors look at it.
Right. And so that's a really tough question. And whenever it all comes down to it, medicine, especially family medicine, I would say even more so than any other specialty, right? We're the form of medicine that is not a specialty, but we kind of are. But more so than any other specialty, we're kind of at the ground level having to determine by practice what works and what doesn't work. And we're told a lot of things. We're taught a lot of things. And, the journals and the, lunchtime programs, convey a lot of things. But at the end of the day, we're sitting in front of the patient reaching an aporia. Okay. So a state of questioning about their condition and trying to help that patient. And so it pushes us to really grapple with things that are not stated, in other offices, not just us. I would argue that, any person, this may border on to your other question, any person who gets a medical education and then finds themselves in the situation that we're in to where we really only have one stakeholder, and that's the patient, then that person is going to grapple with hard questions in a way that produces maybe helpful knowledge, right? Or helpful practices, different than knowledge.
All right. So back to the definition then.
Yes.
What let's define some of those other words in there. So like
Okay.
you're talking about an organism's ability to
Adapt.
detox
and
adapt.
Yeah.
Adapt to what?
Okay.
What does that mean? What does that mean in everyday life, or as I would say in English?
Yeah, I got you. You could say that, right? It's okay. So what is life? Life is, I mean, okay. Let's define an organism as a human. I think we can easily do that. Y'all don't train dogs, right?
I think that's I think that's our viewership is mostly human right now.
So we'll define an organism as a human. Human goes through life dealing with strain.
He's got a cheat sheet on. He's got a big whiteboard over here that's got a bunch of diagrams.
Yeah. And it's funny because this part of the diagram y'all actually influence quite a bit. And this Whoop band, I promote Whoop like actively because it's such a cool technology. But what this technology kind of revealed to me is that life is actually about strain and stressors, right? And that strain can come in the form of many different things. That strain can come in the form of induced exercise. It can come in the form of being chased down the street by a dog, right? Or it can come in the form of like mental strain or emotional strain, or lack of sleep strain. You know, it's which is the inability to recover or detox. Right. So that's where that kind of plays into that definition. Where is I going? So life is this like dynamic of strain and recovery. And I'm using the Whoop terms for that for very specific reasons. And as we go about the strain, some of it intentional, a lot of it unintentional, and we recover from that strain, our ability to kind of go through that dynamic is how I define our health. Okay. We have this bad habit of defining health in medicine as a lack of dis-ease, right? And I argue for very academic reasons that is a terrible definition of health. And
Can you say that? What's the bad definition of health? Can you say it one more time?
A lack of dis-ease, right? Okay, so we can tear that down if y'all want. So dis-ease. I mean, it's exactly what that word sounds like whenever you break it up into its like two components, a lack of ease, right? And so, well, we know now that life isn't about a lack of ease. It's it's about the ability to meet stress and strain. Okay, and I'm defining stress as the accumulation of strain. Okay, the ability to meet strain, I should say it like this: strain and subsequent stress, and recover from it, and then adapt. So there's the definition.
Now, in the gym world, a way to
Yes.
think about this would be you expose yourself to a stimulus of a load in weightlifting. You're exposing yourself to a stressor. You are straining the system with that specific stressor. And the idea is that when you get under load, a couple things happen. You have inorganic, like your neurological, like your body's like, hey, we had to produce a lot of force. Let's learn how to more efficiently produce that force. Like, let's learn how to use more musculature at the right time in the right way. But there's also the organic stress of like the actual tissues, the tendons, the ligaments, the bones, all of that. That stress, straining those systems, both of those indicate to the body of like, hey, we endured greater strain. How can we recover so that next time the amount of effort it took this time would be less? So like we're stronger.
I 100% agree with that.
And so now that's a single system in many, right?
Yes.
But that's talking about, that would be a way to look at stress, strain, and
many
recovery.
systems in one.
I think what I like most about your definition, what jumps out versus the traditional definition, The traditional definition was a lack of a negative.
Yes.
So basically, it's not negative, as
Right.
opposed to yours is not just a neutral, but it was this next step, right? It wasn't just stress and strain, and can I recover back to neutral? It was and overcome and adapt, which is, I mean,
Yes.
we'll throw in our phrase 1% better, but it's
Right.
but it's
Right.
whatever the next step forward is. It's not a not negative. It's not just a back to neutral. It's actually an improvement.
So what you're saying is
Health
health
is
is not
positive.
a static. It's not a state, right? It's more or less an ability. Whoa,
It's a verb.
I know, right?
We should write a song called "Health is a Verb."
Dude, it really is. Like whenever you actually get down to it and you get down to some of the more updated thinking on the matter, it's a fittedness. Okay. Well, okay. Fittedness is an adaptability. So it's not even the ability to adapt. It's the improving ability to adapt. So, whenever I know we've talked about on several occasions, right? This kind of metric that was put out by CrossFit like several years ago, where you have healthy and then you have fit. So you have unhealthy. I'm trying to think of the diagram.
Sickness,
Sickness,
wellness, fitness.
Yes, exactly. And we've talked about how we're kind of on this side of the continuum from sickness to wellness, and you're on the side of continuum from wellness to fitness. Okay. But your ability to move the needle is fittedness, right? Your ability to actually adapt. And I would say that's the thing we're all y'all in the gym, the exercise, the intentional stressor world, right? I'll even go one step farther. The intentional controlled stressors that we call exercise in order to produce a strain that we can then adapt from. Okay, we're all in the same realm in that regard, but maybe dealing with separate populations in general, and in a lot of ways we're not, because we're treating a lot of the same people. And I say treating, y'all are coaching.
We're not allowed to use that word, but
Yeah.
I agree with the sentiment.
Yeah,
On a legal level, if anybody's watching.
right.
And what Doc's talking about is it's a continuum in CrossFit where it's like it looks like a rainbow. So the shape of a rainbow. Over here, you've got sickness, and then you've got wellness in the middle, and then fitness is the exact opposite of the sickness piece. And so the idea is that as you move closer to fitness, if you were to say stop all of the controlled, intentional stuff you're doing,
Yes.
you would start to move back. But the degree to which you are closer to fitness is the less sliding into sickness you have. So if you're over here and you're real fit, and something happens and you can't work out for a month, can't practice your nutrition or whatever, you will slide back, but you're not sliding back into sickness. You're sliding back towards wellness. Where if you're like just under wellness, but closer to sickness and you stop, it would slide back towards sickness.
Yes.
And so our goal is fittedness is the ability to move forward on that.
Yeah.
And maintain your position if things that you can't control go awry.
I would agree with that. And then age happens. So that's the inevitable thing we haven't solved that we know of, is aging. Right. And so I would say it's very well established that the more along that continuum toward fittedness that somebody can obtain, the less quickly they slide backwards as they get older. So you're also kind of affecting that aspect as well.
When CrossFit teaches that sickness, wellness, fitness continuum, they talk about they use the word buffer in this sense, and
That's
so
a pretty good way to think
and so
about
it's
it.
not even just, oh, I fell off working out. It's like, hey, something real happened. Like I tore my Achilles, or I, like my grandmother passed last summer, and it was just a weird month of travel back and forth. I was definitely not in the gym as much as I could, but with a buffer built up, it didn't negatively affect me the way it would somebody that was not working out, was not
Right.
healthy in any sense. that person slides back to back into a danger zone, not just into the, hey, let's just pick it back up in a little bit. That's a very different thing when you've made it towards the right side of this continuum we're talking about.
Yeah. Yeah. Or you think of a healthy person that experiences a sickness or a car accident, they're maybe affected less than somebody who is not healthy. I'm using that term healthy very operatively, right?
I mean, we can even get into the taboo subjects of like COVID and stuff like that.
I just had it this week.
We look at how people.
Yeah.
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 You good?
Oh, I'm great.
Okay, I'm just checking.
Yeah. My Whoop date is back to normal.
Yeah.
Right.
Yeah. That's how you really know.
Yeah. Yeah.
How did you know it was coming?
Well, okay. So, first of all, my respiratory rate went up. Okay. And then my pulse, my resting heart rate, and my average heart rate went up. And then my O2 sat went down. And then about day 3 or 4, because you got fever, you have chills or whatnot. And then as that stuff goes away, the fever, the chills, it's the body actually adapting to and overcoming this virus. Then the biometric markers then seat themselves back where they need to go. And it's kind of nice to kind of just observe that in yourself, being scientifically minded, that, okay, everything gets off in a very expected way and then it comes back on in a very expected way. And so that was interesting. But right, it's like, okay, COVID.
But you even see how different groups, obviously exceptions, there's a lot we still don't know, but how you saw different groups as you would group somebody on that continuum.
The biggest risk factor was general health as far as COVID goes. Whether it was cardiometabolic health or obesity or age, those predictors matched very well as far as how hard of a time somebody had with COVID. Were they hospitalized? Were they put on a ventilator? And so, yeah, it kind of speaks to exactly what we're talking about.
So you mentioned, it's the body's ability to handle strain, stress, adapt, all of that. So how does that work? Okay, so if the traditional model is absence of disease, simple example, we had Joe on, like he was on blood pressure medication. So like the idea of blood pressure medication is in the typical model of the absence of disease. The idea would be like, we're just trying to we want the absence of high blood pressure. Therefore, we prescribe the medication that can make some state changes in the body that change the reading on the blood pressure cuff, but it doesn't necessarily change the mechanism of the increased blood pressures, right? So that's really like a traditional, something that a lot of people might hear.
You're getting into a very murky process, which may be worth unpacking.
Well, my question is, and this is, I think, what's cool that I've learned about you, because I see you, my daughter sees you, like we see you. So someone comes here with high blood pressure, right? Like, what's the difference of the traditional model of lack of disease to yours? Like, how do you treat or interact with someone? And let's, kind of preface it by saying this person's willing to adjust lifestyle factors, right? So so say they're
that's
like,
an
okay,
important factor, right?
Yeah, and I think that's a good thing to say because it is as detailed as the stuff that you deal with. It's hard to not give some sort of like indicator of what type of person this is. But let's say someone comes in, they're like, okay, I feel like, I've been taking this blood pressure medication or my blood pressure is elevated, but I don't want to necessarily go through the traditional treatment that my dad did because it didn't serve him very well. That's the type of person walking in.
I like how you put it.
So, well, I think that's common. I think we're starting to see people where they're like, I'm not sure that this is the way.
Oh, which brings up a whole another point too. Okay, but I won't go down that rabbit hole.
So, yeah, we'll start with the first one and then maybe we get there. So,
so somebody comes.
They walk into you. What do you do differently?
So I call this a secondary disease, right? Okay, what's a primary disease? MI, right? Or heart failure or cerebrovascular accident. So there are things that show up that are diseases, right? And then we have things that are warning signs of those diseases that we treat like diseases. And blood pressure would be a really good example of that. Blood sugar being a really good example of that. And then this is faltering with our, as time goes on, but cholesterol, hypercholesterolemia or hyperlipidemia, cholesterol panel being off. Okay, is that actually a disease, or it's a risk factor for the disease, right? But for the purposes of practice or whatever, we call that a disease, and then we treat it like a disease. But you're right. You have somebody that comes in and they don't want to be treated like their dad was treated, right? And so to them, taking a pill is a separate type of risk factor, right? Okay. Well, first of all, we treat it like a secondary disease, and we tell them, we say, okay, we try to gauge where they're at in this continuum. Okay, what are their risk factors for like a true MI, and how urgent that is it that we actually get this?
Can you
risk
tell people
factor?
what MI and cerebral
yes.
vascular, what those things are normally called?
Yeah, myocardial infarction, aka heart attack, and really I should not use that term because really it's atherosclerotic cardiovascular disease. Okay, ASCVD, right? And this is it's basically blood vessel disease around the heart. Turns out in the brain. Turns out all over the body, and it's what we Americans die from. One of the things we Americans die from, besides cancer, neurodegeneration. Those are other big ones.
And then cerebrocardial, that's a stroke.
Yep.
Yeah. So basically, you're saying
Cerebrovascular, but yeah, I gotcha.
oh, cerebrovascular.
Yep.
So you're saying those are the diseases.
Those are the actual diseases.
Okay.
Okay. But we're treating high blood pressure as a risk factor for those diseases. But if we have somebody who is motivated to treat the disease in a way that it can only be treated, which is lifestyle modifications, then that's the right answer. Okay. Now, sometimes that means in lieu of medicine, and sometimes it means that no, we need to address this while that person addresses some of the lifestyle modifications, right?
Because there's a safety thing. Like, if blood pressure's too high too often, we might use medication to bring it down.
Or if it's not low enough, often enough. Mm-hmm. It's like too high of blood pressure can be very dangerous. Not having a resting blood pressure low enough tends to be the real danger.
Really?
Yeah.
Tell why?
Because whenever the vascular system, I say this, and not just the heart, right? But the vascular system contracts and relaxes, right? And that produces pulse. And okay, but here's a really good example. It's like my AC at the house, right?
In
my
Texas, when it's 105,
yes,
this would be great.
It's been horrible.
Yeah, guys, it's September
August.
and we're in the 100s with the 106 in the forecast tomorrow. So
That's right. Okay, part of the problem was the 106 or the 110 or the 113, right? And that produced my elevated like AC bill, right? But part of the problem was the 95 at 1 o'clock in the morning, right? So
good example.
Yeah, my temperature in my house didn't have the opportunity to relax back to a healthy level, right? And so therefore it just racked up AC charge, right? Which was the disease, is make doc go broke. Right? Yeah. But you can view blood pressure in much the same way. It's like part of it is how high it is, but part of it is how low can it be in a resting state.
So you're not even recovering from the strain of the actual system that it needs to be. You can't live without your heart pumping.
Yeah, and that is a horrible oversimplification. I would say it works for
what we're talking about.
I understood it.
Exactly.
It made sense to me.
So it's cool, and that's cool because now people understand. Like, hey, like, okay, this person comes in, they have high blood pressure, and then like the problem is the inundated system has taught us like, what can I do right now to lower my blood pressure?
Right.
And it's like, I'll take the pill, right?
Take a blood pressure pill.
But what we're also
Right.
seeing is, we're seeing evolving research. We're seeing a lot more open conversation in the medical community. Also, medical to fitness is we're seeing more of that. That's what this is, But so someone comes in and they're like, okay, cool. Like I have elevated blood pressure, but I don't really want to take the medicine the rest of my life. So you say the solution is lifestyle factors.
Yes.
So you as a doctor, how do you act and work with that person to help them through that process? Because that's probably the difference between you and
I would say in our system, in our emerging medical system, that's the biggest factor, which is actually changing, is, get this, the patient's ability to take part in their own health. Wow. I mean, that's no small thing. It's like, okay, we got a lot of new cool drugs. We're getting more new cool things like therapeutics, peptides, hormones, it's like all the things. But the factor that's changing the most is what the capacity of the patient to take part in their own well-being and healthcare.
sounds like having a coach making a workout doable for you so you can start on the first day.
Yeah, which was one of the first things I said is like, I got a lot of patients that come to me and they should be coming to you. Right.
We're working on that bridge.
True.
We're working on that bridge. But this is human psychology now. Like
Right.
really what we're getting into is operant conditioning.
Yeah. Okay. Explain that one.
So basically what's happened is there's a pattern of behavior that's been accepted long enough that there's no understanding of the origin. So like,
Oh, wow. I like
so
that.
like when we treat blood pressure, the standard is you take blood pressure medication because the key is in order to be healthy, your blood pressure needs to be down.
Right.
So that's been done long enough to where some people don't.
I'm not writing what you just stated. I'm just saying, yet operant conditioning in the realm of blood pressure seems correct.
Yeah.
Yeah.
And the it's Pavlov's dog is the actual experiment if you ever want to look it up. But basically it's been done so long that people think that's the normal way to do it. And so what's happened so far is the belief that the actual way to be healthy is to lower your blood pressure, not to ask why the blood pressure is elevated in the first place. And then understanding that there are factors that raised it, not that I need to do whatever I can do just to get it down at any cost, which is I just take medication the rest of my life. I can do that. But we've been conditioned to think that's the only way sometimes. Like I think there's some people that they might believe there's no other way.
I mean, we have those patients. It's true. And then we try to advise them on how to go about bettering their stance, right? With regards to blood pressure, but it could be blood sugar.
Well, this is anything. This is anything you want to talk about of what you would go to a doctor for.
Right.
We're really talking about anything. It's relevant because I was talking to Joe last week on the podcast. You ought to listen to that if you haven't. But that was one of his big things.
Publishes in 2 days publishes tomorrow officially.
Yeah.
Okay.
Drops tomorrow.
I'll listen.
But for him, like his dad had high blood pressure and heart issues. His grandpa had high blood pressure and died from heart related issues. And so basically he was told like, hey, it's hereditary. You'll never get off this. Well, 3 months ago, he got off of it through exercise and nutrition. And so
He was on it, 14 years, I think was the number?
15.
15?
And he said he just got off his cholesterol meds. They said you'll never get off those.
It's a story that needs to happen more.
And get this.
Yeah.
This was the not funniest. This was the coolest thing he said. He said, for 15 years, I always walked in thinking I was going to fail the blood work until the one where I knew I was about to get off my cholesterol
That's
meds.
awesome.
And so he's like, it was the first time in 15 years I thought I was going to actually pass the test. But again, he started by saying, and he told me this personally before he ever did the podcast, ever did anything. He told me, he said, Jonathan, he's like, this is messing with me because I trusted this system and lived by it. And then now you guys have worked with me. And it's not just like, it's not a pat on. Yes, it's good work that we've done and we have a great team. But like really the reality is what we're trying to talk about
Well,
here
it should
is
be
like,
a pat on the back.
Yeah, but
that's
still,
a huge success.
But there's so many people that still believe what he believed, which is, hey, like this is the only way. This is just how it is.
Right.
And that's we talk about the frame of the authoritarian, which is like, it's this way or the highway,
Yes.
and so.
Yes. Okay. So which bats on yet another complex issue? Our
Doc's full of complex issues,
I know.
guys.
Well, our conversations are because they mount very quickly to aporia. So that's another like key word for me. It's been like my key word for like a year now.
Pause. So thing about Doc is Doc writes a lot, reads a lot, and so like when he uses these words, he's come to these words because he's had thoughts, and finally through thinking about through all this came up with words to define it. So when he has a word, like it's not like, oh, it's just one I thought of. He's like, man, I've been trying to figure out how to explain this, and then this is how I've come to. So tell us about the word.
Correct. So, and I will credit John Vervaeke, cognitive scientist, for this word. Okay, but apparently it's Socratic according to him, right? But aporia. Here's a good way to define aporia. Is because I had a very instantaneous moment where I recognize what that word meant. Okay, I'm sitting across. My daughter's taking a math exam, right? And I'm sitting across from her. She homeschools, and she reads the question. She's 13 years old. Reads the question, okay, and looks at it, and you could just see that look come on her face, right? And it was, excuse my language, that WTF like look, that moment where she recognized she had no clue what to do with this information, how to even like start like solving the problems. So it's basically aporia is this like complexification to the point where you realize you don't actually know what you need to know. And then as an adaptability producing mechanism, right? That aporia causes you to go seek out some other answer, some other method, some other whole different insight of how to deal with that problem. One thing I noticed about our conversations is they complexify to the point of aporia very quickly, which is kind of cool. And so I very much appreciate that about our dialogue.
Yeah, because at the end of the day, what's different is we're trying to actually get people to change their behavior. You know, that's what we're trying to move towards is, and I say this when we do an intro to the gym, it's like, yeah, I want to help you with your short-term goals, but you know what I really want is I don't want you on the yo-yo next year.
Correct.
Like I actually want this to sustain. And
so
then,
you're dealing with a psychological, well, what does that mean? A psychological problem?
it's a very complex question, Doc.
No. Right.
Well, let's hear your version of it. I mean, we talk about our version a lot and stuff on the podcast, at least. Like that was a question I had from maybe a few minutes ago.
So
I know my answer, but like you have somebody that comes and sits down and you're like, hey man, I can give you some medication to help us in the short term, but the long term is do these things for your health. Like how do you enforce that, encourage? What does that look like maybe a little more practically for this answer?
Okay, let me start here. Okay. And this was a big recognition that I've had is a massive part of the problem is that we don't understand the problem very well. Right. Okay. So we have some garden variety observations that seem to work for a lot of people with regards to health. Okay. If somebody comes in, they have a blood sugar issue, right? And I can hand them a pretty garden variety recommendation and achieve lowering their blood sugar, achieve that short-term goal with a lifestyle recommendation, right? But whenever it comes down to fully understanding what's going on with that blood sugar or that blood pressure or the triglyceride to HDL ratio, you could go on and on, their inability to recover at night, whenever they sleep, their insomnia, their anxiety, it's like literally the list goes on and on. Whenever you get down to what we actually understand, it's getting better, but it's not there. And a lot of intelligent thinkers think that, well, we're just really kind of deceiving ourselves in what we think we know about the problem of human existence. And that may be true. So that in and of itself is maybe a problem, because then what do you tell the patient or the exerciser, right? The gym member, what to do? and you're left with kind of garden variety recommendations. Don't eat so much sugar. Well, okay, sometimes I can tell somebody not to eat so much sugar and it works, right? But sometimes I have to tell them not that. I have to tell them what they should eat instead. Okay? And maybe that's the correct answer. Or sometimes I can identify the one thing they're consuming that they just need to stop. That they're consuming a lot of. And sometimes that works to mitigate that short-term thing, right? But that's why I said a lot of people come to me with what they should probably be coming to you guys for, is they need a coach. They got a doctor. Doctor identified the problem. They need a coach to coach them in how to fix that problem, because it is a complex psychologic thing. How many times? Okay, so yeah, y'all are a poor subset of this. So how many times?
In a good way.
Yeah, yeah. Okay, how many times do you think some non-gym person wakes up in the morning, decided that they are going to do something that they don't succeed at doing? Okay, use exercise as an example. Or they look at their week and they're like, okay, I'm going to exercise on Monday, Wednesday, Friday for this long. They know exactly what they're doing. And then Monday rolls around, the end of the day, and they're like, yeah, and they just go home, right?
I mean, we track this with our members, and in theory, people that are members and pay us money for this accountability are going to be on the
more likely
on
to
the
use
better
it.
side of this.
Yeah.
But we track this, and I mean, I don't know if I want to say as much as like half of the members, but I might say even more than half don't get as many workouts in as they intend to on a weekly basis. And so to answer that question, we're probably on, like you said, we're probably on the better half of the subset, and the people are still not getting to their intended number per week. And there's even a group, I don't know, I might put it in the 20 or 25% range that may not make it at all in a week.
Yeah, gotcha.
And probably, besides vacation, has genuine full intentions of,
and it just doesn't happen.
On Thursday or Friday, okay, yep, next week I'll get into it as members. And like I said, that's our subset of probably the better half of this. But the average American, or your average patient, you probably don't have only gym goers, right?
I do have a few, but yeah,
but your average patient,
yeah, doesn't usually, right? Okay, so why is that? Now we're into psychology.
This is my job.
Yeah.
When they come meet me at the gym.
Yeah.
Well, it's both of our jobs. I mean,
so is it a lack of will, or is it a lack of education? Like, do they not know the significance of the problem? It's like they might think they know, but do they not understand it at the core enough to actually show up?
I would say that's one of my answers.
Yeah, they're not. Okay.
I have a good thought on this. I mean,
Yeah.
were you going to say something?
I was just gonna say, I think everybody knows in theory what they're supposed to eat, but like you said, to the extent to know how serious it is, and actually know that, hey, if you just swapped a couple of things in your nutrition, you could probably kick a bunch of these medications and teach your body to adapt again on its own.
like-
I don't think people realize it's that deep and that serious and that simple. I think I definitely think there's people that if you say, hey, what's a healthy lunch? They're going to give you an answer that I probably wouldn't be proud of.
Right.
But there's also a ton of people that, man, that's even what they say, though, is still probably better than what they're doing. And they're not even doing that. So
it's tough because I have a lot of people who tell me they eat healthy. I have that instance that you just
I had a
mentioned.
salad for lunch. So a bunch of romaine lettuce,
Yeah.
no protein, and then I dumped salad dressing on top. And it's like, okay, I mean, that was better than cookies. High five for that. But that's about the only thing it was better than.
Right. And I would say the same thing. It's like, yeah, I eat healthy, but they even hand me definitions that's not salad, right? And they consider it like, yeah, lean cuisine,
So I would say that. So that was my other answer. The personal answer to that question is, I do think people have been poorly educated, whether that is the education officially in terms of schooling they were brought up in, or whether that's the education of society, the system, government, healthcare, marketing, commercials, big food, and their influence, like that category. Those are my Those are my two answers to the question.
Misinfluenced.
Yeah, so they think they're educated and they're eating mini wheats for breakfast. And it's, well,
I would hope, and I do. I sincerely often hope that we're coming out of that era, and this is speaking to the same, aspect I was talking to before, is that we're entering a new era where patients are becoming aware of that very thing, this kind of misinforming of health for the sake of their pocketbook. Like, did that actually happen? That happened. No, it really did. Yeah.
still is.
Still is. Right.
Well, way back, I mean, first thing you said is like the actual person that matters in your healthcare model is the patient, right? And so they're paying to be here.
Yes.
Whereas the traditional model, there's a third party that's involved in it that influences a lot of the process, which is insurance.
Yes.
And so that makes it different and harder sometimes, most of the time, to do anything but what's been prescribed for years and years and years.
Yeah, that's tough. So I wouldn't believe it were true if I didn't actually practice in that environment. But the traditional healthcare system is broke as far as primary care goes. Okay, I'm not speaking for any other subset of the healthcare system. It's broken a lot of other ways, I can tell you that for sure. But it's definitely 100% broke as far as primary care delivery goes. And it's because we've entrusted a third-party payer into the doctor-patient, or I will make the argument very sincerely that it should be provider-patient relationship, right? And so whenever we introduce the third party between the provider and the patient, things went awry very quickly. And so the state of things in my previous practice situation, well, my nurse practitioner and I shared 3,000 patients. And we think that it may have been more, right? And we were trying to see, between 30 and 40 together patients a day, and which limited our sanity and it limited our time, and it completely limited our ability to fully kind of grasp the problems that our patients were dealing with, and then attend to those problems or help our patients attend to those problems. And so we went through a bout of insanity and then just had to get out. And so I will say here at Enso, we have 3 providers, myself, Casey, and Kelsey. And as of today, we we each have 333 patients. And we share all of them. Like we have what constitutes 333 patients per provider, but then we look at the 333 times 3, look at those patients as everybody's patients. And so we treat all of those patients as a team. And it's corrected many things. And I will say my average time with patients is between 30 and 45 minutes per visit, which is crazy.
My average duration is 60 to 120. I think so.
Yeah, I think so, right?
We get talking.
Yeah, it's true. It's true.
Which
And some patients don't
it's
want
less pressure. Like there's no pressure to perform on either side, right? Because I remember I've been in the doctor's office where I'm like, well, he's gonna be in here for 5 minutes, so I gotta be ready to roll. You know what I'm saying?
Yeah, that's a big aspect to it. Is preloaded notions of the interaction, and so I use this example actually on another podcast. Can I pitch them? Gut Check Project.
Sure.
Gut Check Project. It's a cool podcast. But use this example there is like, okay, let's just take something minor, strep throat, right? Wake up with sore throat, and you're going to go in. Well, you think you know what you have, which is strep throat, right? Whether you have it or not, right? And you think you know what it is, okay? And then you have a predetermined amount of time. You think you know what you need, okay? An antibiotic. So you think you know what you have, you think you know what you need, and then you're faced with the barrier that you're only going to get 5 minutes, 5 to 7 minutes actually, to convince this person of what you have and what you need, right? And so that presents a complication. Okay, so you're showing up to the doctor's office with a preloaded conversation. That's problematic whenever it comes to your healthcare, because the complexity of your healthcare requires a dialogue on the part of the provider and on the part of the patient, because it's aporia producing. And I'll say, whenever I walk in with a patient, I might suspect I know a little bit about what needs to happen or what recommendations I'm going to hand them or how I'm going to treat them or what medications I'm going to prescribe. You know, I get a patient who has a UTI and she's had a UTI 5 times in the last, 2 years. I might know, okay, well, she generally does well on this antibiotic, or she's been on this antibiotic so much in the last 2 years, I need to steer away from this antibiotic and go with something else. I may know in that generality, but I don't really know till I sit down and we explore together her problem and come up with a decent solution. And then I have other patients that don't want that long of a conversation about something that they see as a menial problem. And then I get to view that situation and say, okay, is it really, do I think it's a menial problem? And sometimes it is, right? And they're calling and they're like, no, just tell doc I need this. Or they're texting me and they're like, hey doc, can you send me this? And I'm like, okay, maybe. And whenever I dig into it, it's like, okay, a lot of times they're actually right. And it's like I give them exactly what they asked for. And it's like, wow, that was interesting. But then sometimes I come to a menial question and I say, oh no, we need to actually sit down and have a conversation. And I would say it's like those specific situations carry all the weight in the world as far as defining for me why we had to make this move, why we had to leave traditional healthcare. And then I will make the claim that, okay, if you're not paying for your medical provider, at least your primary care, somebody else is, and you need to be skeptical of that situation. It's like 100% of the time. So, wow.
Flashback to episode 1 with Dr. Ryan Perez, the physical therapist.
Yep.
Same thing.
Same
is
thing.
that you pay for care, but you don't get proper treatment.
Correct.
You pay for the participation in some form of physical therapy, but it's not dialed into who you are, where you're at, and what you actually need.
Correct.
Again, last week, Joe on the podcast, I think this was not podcast, but this was watching him and then our nutrition coach, Melody, interact. And she's been on a few times as well. But I know the interaction between the two of them and her helping him through all of this. One of the things that she says all the time is that at the end of the day, you are still paying for a service. And so if you do not feel like you're being served correctly, proven by data of I got healthier, my metrics improved, my ability to adapt improved. So you look at Joe being on his cholesterol meds for 15 years.
Yes.
The data would say that whoever was providing care for him was not providing care. And so he should take his money or via the insurance loops money to another provider. And that's a point that Melody makes all the time of like, yeah, I mean, you got to give me a chance. You're not just, doctor hopping, but like if you've been there for 15 years and you've seen no improvement, and in fact, you've gained 100 pounds. I mean, you guys should see the before and afters of Joe. Like,
yeah,
I don't feel like that doctor was providing care or the proper guidance. Again, there's also the patient has to put in their half and, the stuff. But like, if that's the proof, that's the data,
then
it's your responsibility as a patient to find correct care and hold, I say, your service provider accountable in that.
And then I'll add even another layer to that. If, it's okay, say Joe went to a very adept nutritionist, right? Somebody who's really good at what they do and they do their job very well. but their metrics didn't change, right? But they walked away with this armed with an increased level of knowledge or an appreciation for healthy food that then affects them on down the line, then in some small way that was very successful. However, I do want nutritionists that can change the metrics, right? You know, just like I need a coach who can affect somebody's ability to induce strain, right, in a very controlled manner. I need a nutritionist that can help a patient appreciate and then change the metrics that need to change, right, whenever it comes down to the line. And I would say patients need that as well, not just me, the provider.
Yeah. Hey, life is short. Like some people don't have 15 more years to wait to figure out and to try again. Like
That's true.
So yes, we are about long-term health. That's what we talk
Yeah.
about all the time.
Yeah.
And so that's the trajectory I want to get you on. But
So
depending how you count your years, I'm not sure we're all like, 15 years will be better now, right? It's a different
Yeah.
thing. Like there is some short-term or medium-term.
what's
Hey man, we got to see some data.
Here's an interesting observation is, and okay, so feel free to debunk this. Okay, so this is my observation. I don't know if it's true.
I'm excited.
Okay, are you ready?
I'm so ready.
So in general,
No.
that's great. Okay.
All right, let's try again.
Okay, let's try again.
Take two.
I'm going to use in general, right? But in general, younger people who come to y'all are healthier than older people. No, reverse that. In general, older people that come to y'all are general as a subset of healthier people, of older people, right? Than younger people. So let me rephrase that. So that was a complicated question, right? In general, older people that come to y'all are healthier as a subset of older people than younger people. So think through that. If you think through the older people that are members of the gym, they're generally healthy older people. Is that true?
Are you saying in the terms of like,
Let's say like a 65-year-old. If a 65-year-old comes to you and
so you're saying old timer, I got my garden out back and
old timer.
I cook everything myself and more getting into that category versus the young.
Confine it to physical fitness, right? 65-year-old that comes in and joins the gym, they're generally a healthier 65-year-old compared to their peers.
I hear your question now.
Yeah. Than a 30-year-old. Not that you that's why I said in general, because you have 30-year-olds that join the gym that are extremely like healthy. I've seen them. Right?
So you're talking about the gap between our 65-year-old versus the average 65-year-old versus
the 30-year-old.
Our
versus
30 versus the average 30.
Yeah. And so what I would make the claim is, if that observation is true, I think it is.
I like it so far.
Okay. That tells what happens whenever people get older is like the range of affecting this unhealthy to fit, what do we call it? Scale? Continuum, right? The ability to affect that gets wider, or it's like the definition of unhealthy versus healthy extends as somebody gets older.
I mean, there's more just basic wear and tear on the body. There's age. There's
okay. It's like a history of injuries.
I'll say just being exposed to whatever,
Right.
whether that's not doing something for a long time or
Poor posture,
exactly, it's just
like
longer
life
to take
of
effect. Obviously, there's 30,
sedentary.
Obviously, there's 30-year-olds out there with a ton of issues, but you would assume more 65-year-olds are having legitimate issues and dying of these real diseases we talked about than your average 30-year-old. So yes.
So how do you affect older people who haven't been like paying attention to their physical health over the past 30 years, right? And then they show up on your doorstep. How do you affect those people? Or how do you coach them? Here we get off into what I think is a scalability of CrossFit, but
I would say, relatively speaking, that your observation is true. I do think it's a little deeper than just a black and white.
okay.
So for example, I think that the people who are boomers,
So what age group is that?
we're really talking like, was it like 45, 50 to 70, 75, something like that?
Yeah, I would say
Maybe a little older than that now, 55 to
55
75.
I would
to
put
75.
55 to 75.
Okay, so
60.
like my mom is 70.
total guess.
But that generation...
Somebody fact check us in the comments.
Yeah.
For sure.
That generation, in my observation, there are people that there's kind of like a dichotomy of some who like really went all in on like, hey, I trust my doctor and I question them none. And then there are the other group where they're like, I just don't believe in that doctor stuff. I think that generation has a more black and white dichotomy than anyone I've worked with. And so the reason I think that the older people, the healthier people show up is because they've already lived that life. And by nature, they've been a little bit outside of mainstream. And so they see us and they're like, okay, I'll try something else. Whereas like people who are inundated with a typical system, I think there's two parts of it. And one is like, if the doctor says that you can't do it, don't do it. And people will say things about CrossFit or functional fitness of like, well, that's probably not a type of exercise you can do. And if you have the frame of the doctor or the authority, you carry a lot more weight than Jonathan, the 30-something-year-old skinny guy sitting across from you.
Oh, that's a good
Right.
point.
And so,
Right.
so I think they're just less likely. Now, can they succeed? Yes. We have what we need to make them succeed, to help them succeed. But then slide back to the younger side. The reason why I think the younger people tend to be, like we have the people, Greg Glassman says, the fit will find you. Like we have those people that they're already into fitness stuff. And they're like, oh, yeah, I want to try this thing.
Yeah.
It's novel. But there are people that come to us in lower ages now, more so, where they're like, man, my health, like I don't feel well, my mental health, like that. And the reason I think is because we talked about this all the way back at the beginning, like the buffer thing, but your genetics have a buffer too. So like when you're younger, you can put stuff off longer until you actually experience a pain great enough that it causes you to immediately change. Okay. So like someone who's 30, they probably got another 10 years before they have the mild heart attack.
Yeah.
Right.
Is that a psychological statement?
No, it is psychological. Yes. Sorry. Yes.
Yeah.
So, and this is it. So humans are extremely adaptable, right? Well, it's also your present environment, even if it's bad. So like when you're young, you can handle eating trash and your body won't have a catastrophic event today.
Yeah. You have a metabolic
And
reserve.
humans
or a
are really
buffer.
good at waking up in the morning and being like, well, I can just do this one more day. I can suffer one more day. I can endure one more day. Well, the problem is with your health, there's a point where you can't come back. And so what I think's happened, I think the reason why younger people, we may not see them is they haven't experienced a pain great enough as a reason to change. Whereas like some of them, they're 30, they've got these indicators, and then their dad had the heart attack.
Right.
But they are not conditioned to necessarily consider the authoritative view. So they're like, okay, yeah, I know I could just go to the doctor, but I don't think I want to do that. And they say that phrase consistently. So consistently, people ages 20 to 40, they'll consistently say, man, I got to do something about my health, and I'm really nervous about getting on medication the rest of my life.
Yeah. Yeah.
So I think it's deeper than that. And so to go all the way back to what you said about how do you get someone to change, the reality is if we can't create a proper view of the future pain of their current behavior, it's humans can accommodate a lot of low level pain, which is like, yeah, I don't feel so great today. But if we can say, hey, like you do realize like 10 years from now what this does and what that could cause, do you know someone that's happened to? And it starts to get personal, then it's like, oh yeah, maybe I don't want that. Maybe the showing up to the gym is a small pain compared to the future pain that I may experience.
Yeah. So
And
inducing the proximity or the severity of their future
100%.
state.
It's called creating a gap.
Okay.
Like you're trying to create the gap from what they think is true to what is actually true. So for example, the healthy eating thing, right?
Yeah.
Yeah, I eat healthy. Yeah, I eat Cheerios every morning. It's heart healthy. It says it on the box.
Right.
Right? But it's like, okay, but has your cholesterol gone down? Oh no. I was like, oh, isn't that what it says on the box?
Yeah.
So you're eating something that's supposed to lower your cholesterol, but it hasn't gone down?
And they never step back to say, yeah, maybe Cheerios aren't healthy.
But you got to get in the room. You can't have that conversation until you get in the room with
Yeah,
somebody,
it's true.
right? So
It's
that's
true.
why we do this podcast, right? This message has the potential to go further than I can ever set foot.
Right.
Right. But so when we get down to this whole, how do you make somebody change?
Mm-hmm.
Like at the end of the day, like it has to become very real why they're doing it. Like it has to become real. And, I love her. Mom, love you if you ever will listen to this, but she's pretty persuaded by what her doctor says. And I've always had difficulty in my interactions with her. And I have to respect that I am a son. I can't just talk to her in any such way, but I realize that there's some reasoning of why she won't do anything, and it's has nothing to do with logical nature of what I'm talking about.
Right.
It's very much conditioning. It's very much a thought process, a belief system. And that's the challenge of what we're all doing here is we're confronting. I mean, it's like David and Goliath, man. That's what we're trying to do, but we're like, hey, like we have a different tool. We're not just coming by force.
Yeah.
We're not just coming by.
So here's an interesting observation. It's like you probably would never recommend your mom just go to the gym. It's like, hey, mom, go to the gym, exercise, right?
Get a coach.
No, it's like, she needs to.
And that's how we help the 65-year-old. My mom's 70. How do I do it? Well, I sit down with her and talk about where she's at before we ever put her through a workout.
Right.
It's like, and you talk about 30 to 45 minutes. That's how long I do an intro appointment.
Mm-hmm.
So before someone even works out of the gym, they sit down with me for 30 to 45 minutes without, like, they don't get through the gates. You know what I'm saying? So, and the reason is we want to understand.
After a screening call. Before
Yeah.
that.
Now we call them first to confirm that we could actually help with what they're looking for, so that we don't book our calendar unnecessarily.
And then they
come and sit down, and we pick up
is
where we left
great.
off. And now we're like, okay, cool. Like this is what it is. And
Yeah.
this is sad. We're talking about this, but I had an intro last night, and the two people, like I was talking to them, and they were like, yeah, I try to go to the gym and I try to, work out, but it never works. And they were about to move forward, and they're like, well, we got to talk to our husbands, their sisters. Mm-hmm. And I got a text message later on, and they're like, yeah, we can't move forward. And this is why. My husband says that's too much money for a gym. And I said, it's not a gym. It's not the same.
You're right.
What is
It's
it?
not.
It's an environmental change.
Yeah.
This is what it is.
You are functional fitness providers,
Mm-hmm.
right? I'm a functional medicine provider. And so I would never recommend my mom just go to the doctor.
Absolutely.
And that could be dangerous. Yeah. That's you show up, you get a good coach, and then you start working on putting in intentional strain so that your body can then adapt, right? And over time, you improve your body's ability to adapt to that intentional strain, okay? Whether it's with the adaptation itself or it's supporting the adaptation with proper nutrition and proper recovery. And that's how somebody's health improves over time. And so far, we really don't have a lot of tools within the medical world to affect that. Yeah.
That's
we're
what you're
working
here
on 'em.
for.
Yeah. We're working on them. It's like, okay, I can improve somebody's fittedness by starting them on some testosterone or I don't like the word starting on testosterone, optimizing their hormone levels, right? Specifically with regards to testosterone. And so that's just one tool that we found that seems to affect somebody's fittedness, right? Optimizing testosterone. Also, maybe optimizing their supplemental support, right? Could be an absolute game changer sometimes. But as far as like throwing magic medicine at people, it just doesn't exist yet. Like there are some compelling avenues of research. It's just not here yet. So we correct disease. I say it now, disease.
I love it.
I'll never unhear it.
I know.
It's like the arrow in the FedEx truck. Once you see it,
Yeah. So somebody
see it.
comes to us with some disease, and we throw medicine at it to correct it. I don't know. That's a tough pill. Tough pill to swallow, right? Yeah. But overall, we are having this conversation. We've been having this conversation for a long time now. and hopefully that needle's moving for a lot of people. So that's pretty cool.
Well, awesome. I'm gonna bring us home a little bit here. I want to give you a chance for any last thoughts, and then we'll talk. I got some other stuff after that, but anything you want to put? Any you want to wrap this thing with a bow? What would that look like? What would you tell somebody? Somebody's still listening. It's been an hour.
Yeah.
What do they need to hear?
Like, man, that's tough. Okay. I would say health is not a state, right? I think that's the most important thing. Health is not a state. It's a condition and ability to adapt. And whenever you think about your own health, think about your ability to overcome stressors, right? And if it's not where you think it should be, then you need to seek help, like right now. Whether it's with us or with y'all, it doesn't really matter, right? Because our goal is to get people to the right place as far as exercise goes. Yeah, so I'd wrap it with that type of bow.
Health is a verb. That's going to be the title.
Dude, I like it. Health is a verb. Okay.
That's the title of your next disposition.
It's my next social media post for sure. You can have it too.
I would say I'm going to do it too.
Okay.
More people that see it, the better.
Yeah, we'll collectively own that one.
All right. I
like it.
All right. We're going to wrap it there. Hey, if you're still listening, a couple of places for you to get plugged in. Can I talk about the nutrition workshop?
Absolutely.
Yeah, I'm going to plug that now. So if you work with Doc, you trust him at this point. Hopefully you're listening, and I appreciate it, tuning in this time. But Doc is organizing something with our nutritionist, Melody. You've seen her on the podcast previously. But we're working on doing a workshop that he can get you as a patient plugged into and start talking with somebody he trusts about nutrition. So we've been talking about this whole thing and lifestyle change and benefit of a coach and whatnot. And so that's the partnership we're working on is providing that coach in a place for you to go to. So, so we're working on that. The first one I've got set up, September 18th was the date that worked best for Melody, and so we're working on that. If that doesn't work, I'll put a link in the bottom later, but join oyl.com/enso-nutrition. I'll put a link down at the bottom. But what the point of this class is, it's a chance for education. We talked about this about halfway through. It's a chance for education on how to make those lifestyle changes specific to nutrition.
Yeah.
Right. And so that's what we're talking about is like this whole conversation we just had about health, how to actually change your lifestyle. Well, this is the practical application to give you we're going to call it 90 minutes of this is the stuff to get. So if you like this, you want more of it, and now you want the practical application rather than three dudes just talking for an hour, this is the practical application. So check the link below. If it doesn't work, comment, whatever. You guys know where to find us, but ask for that. We're going to try to do that on a monthly basis in very small groups because we want it to be intimate. We want you to be able to ask questions. We want you to be able to get plugged in so something actually happens, not just thrown out there on a YouTube video or something like that. So anyways, so look for that. We're excited about that one. And then if you're not with Enso or not with OIL or whatever, I mean, I'll throw links at the bottom, but get plugged in. So Doc, we're in the same parking lot. We're at the other end. We'll see each other on walks when we just need a break and some sunlight and wave at each other type of thing in between work. But ensodirectcare.com.
Yeah, ensodirectcare.com.
But that's how you get plugged in. He is a direct primary care physician, family doctor.
And it's not just me, it's my team, right? So
like I said, team of
just
three.
like with you guys.
Team of three.
Team of 10 now.
Yeah, it's up there.
Yeah. So it's because every member in our team has just as much affect in patient care as I do. So it's and all of our patients are all of our patients as a team.
I love it. We do the same.
Yeah.
I like that. So yeah, if you want to get plugged in with Enso Direct Care, see a doctor that'll actually sit down and talk to you and figure out what's really going on. Not a 5-minute
Or
plead
provider.
not a
Right? Not just a doctor.
Yeah.
Right?
But not just a 5-minute plead your case
Yep.
thing. If you want actual help and service, that's the place. And then
I like it.
hey, if you need a gym, we can talk about that. But I want to make today about him and
Cool.
his team. Awesome, man. I appreciate it. Thanks
Yeah,
for being
it was
on.
Great conversation.
It was a good
Yeah,
one.
thanks for coming over.
We'll do it again at some point.
Yeah,
We'll
heck
invite
yeah.
you back to our studio
Heck yeah. I'll see you guys next
in
week.
your own office.
Yeah.
All right, Doc. Have a good one. Thanks for listening. We'll see you guys
Adios.
next time.
See you guys.